Hi guys, how are you doing today? Uh, just setting up a comment. So today, Das Ka Dam from ENT. I know आप लोगों ने already तैयारी की हुई थी and the exam dates have been pushed, but this session is for your quick revision. So इसमें ज़्यादा detail में नहीं जाएंगे, but what I have done is to make it easy for you and make it important for you. I have collated all possible images that are very commonly asked, especially in the NEET PG exams. And अगर आप trend देखेंगे over the last few years, a lot of questions are coming which are image based. More and more, first it used to be only 10-20%, and now almost 70-80% of the ENT questions at least are being image based questions. And whether it's the exact same image or around the same topic, a lot of image based questions are coming. Even we are seeing also in INI-CET, an average 60 to 80% of image-based questions. So what I've done today is to collate all possible images that can be asked. The more visual, many students have very good theoretical knowledge and very good MCQ-based, memory knowledge. But when an image comes, they are thrown off because आपने देखी नहीं होती है. You don't know what it looks like. And what I've done today is I've collected especially those images which look very similar, where you can get confused. You're not sure which is the right one, and they look very similar. So I thought let's do this over the next hour and a half, and wherever there is some theoretical discussions, you can ask me a question and I will deep dive into it. Otherwise, we'll just stick to these image based questions and we will move ahead. All right. So before we start with ear, good to know what are these parts of the ear pinna. Because whenever there is an image-based question on ear pinna deformity, the options may be कि यार ये वाला part में deformity है या what is this, and this time many students find this confusing. So first we'll start from here. Okay, so this that you're seeing over here, let me back. This part is an important part. This is called as the crux. The crux of the matter, जैसे बोलते हैं ना, crux is like the main thing. It's the starting point. Okay, so the crux of the helix. Okay, this is the crux of the helix. This is an important part. It's an important landmark also, and many deformities largely occur in the helix. So this is the helix. Okay, ये जो this whole thing is the helix. Helix basically means curve, right? So everything that is curving around, this is the helix. And this opposite to it, see, this is curving in such a way that it is cupping inside, but the one that is projecting down, this is the anti-helix. Now, most of your ear deformities are between the helix and the anti-helix. Anti-helix has two crura, 1 and 2. These two are called crura. They're crura. Okay, crura of the helix and anti-helix. ಕೆ ನಮಸ್ಕಾರ ಚೆನ್ನಾಗಿದ್ದೀನಿ. Very nice to see some Kannada in the audience section. All right, any other questions ಇದ್ರೆ ಕೇಳಿ. Otherwise, I'm going to do this English, Hindi, Kannada, mix, whatever language you want, multilingual we can. So, all right. So if you understood the helix and understood the anti-helix, what you see below over here, this is also an important part. This is called as the tragus. Okay, and opposite to it is the anti-tragus. And this middle point is the intertragal junction. Here many questions come in this intertragal area, especially the incision. Okay, there is an incision between this there is an incision called Lempert's end oral incision, and this incision is made for meatoplasty. Okay, meatoplasty, which is for the repair of the ear canal, and this place has no cartilage, so you make this incision over here, and this intertragal area is also called as insula terminalis. Incisura terminalis is this space between the crux of the helix and the tragus. This below is the intertragal area, so don't get confused between these two. Incisura terminalis is above. Okay, this is above. This is the space between the crux of the helix and the tragus. That's why I said this is an important part. This is where the incision get Lempert's meatoplasty. This part below is called as the intertragal junction. Here you can feel that there is cartilage, but in between the incisura and the tragus, you will feel like your finger is going and there is, no cartilage over there. And lastly, these are the other two areas that you should know. This is the Simba concha. This is the cavum concha. And this lower part is the lobule. Okay, this problem. Right. Now, once you know these, we'll be able to tell what are the deformities. Okay. Now, sometimes this whole ear may not develop, and this is also asked. So generally, this part of this ear where there is poorer development, it's called microtia. Microtia means small ear. So microtia basically means the ear itself is small. Normally the ear has to cross above the level of the line of the eyebrow. If it is smaller than that, is microtia. If it is functional, the ear canal is there, it will usually be grade 1 and grade 2. Grade 2, it is just 50% smaller. But this is the trick. If the canal is absent, if there is no ear canal, that is when it starts with grade 3. And if there is no visible or very small tag that is there, then it is grade 4. Okay, so this is grade 3, grade 4 have been asked many times in image based questions, and people get confused. If there is a very small remnant of the ear and no canal which is seen, or absolutely nothing seen, then only grade 4. If you can see one or two parts but no ear canal, then it is grade 3. If you can see the ear canal, it will be grade 1 or 2, which is based on the size. If 50% se zyada chota hai, then it is grade 2. If it is more or less looking like the adult size but overall it is just little smaller, then that is grade 1. Okay, now each one of these has been an MCQ that has come in the past. Okay, we'll take it one by one. Okay, without wasting too much time. This first one is bat ear. This is asked a lot. Bat ear has a name also called as otitis. All right. Fourth grade is also called anotia. Yeah, that is right, because there is no ear. So fourth grade is called anotia, and in third grade, where canal is not there, it is called oral atresia. Okay, so micro is small, anotia means no, and oral atresia is this. Treacher-Collins syndrome is related to grade 3 or grade 4. So Dr. VK is saying, so Treacher-Collins is related to grade 4. Okay, anotia. Now, bat ear. Okay, so bat ear is basically a problem with the antihelix and the scapha. So I told you over here, you can see this is the antihelix, this part. This is antihelix. This antihelix is poorly developed. All right, that is the important thing to know. If it is not developed, it forms cup ear. Same bat ear, if antihelix is not developed, it becomes cup ear. But poorly developed antihelix and scapha, making it look like a projected ear, that is bat ear. This ear that you can see next to it. All right, now we are going to number 2. This one, this is called Stahl ear. Stahl, S-T-H-E. Okay, Stahl ear, basically what's happening is this normally will have only 2 crux. I told you there are only 2 crux over here. This one over here and this 2 over here. Okay, there are only 2 crux. Here you can see that there is this zigzag line, and it becomes 3 crus of the this scapha, and that's what is the abnormality seen in Stahl ear. This is also extremely rare, but because of this visual teda meda part of the antihelix in the scapha, this is called as Stahl ear. Scapha is this space which is there beneath the helix and the antihelix, that space. All right, yeah, it's also called as the elf ear. If you've seen Lord of the Rings and you're a fan of J.R.R. Tolkien's Lord of the Rings, you will see that this part having that shape, giving it a very characteristic elf ear. So that's another drug of choice has told us that that is also another name for it. All right, historical evidence, there is this other ear that sometimes the examiners ask called Mozart's ear. Mozart was a musician of popularity. He had this problem where this ear canal looked like a little bit of a slit, because the antihelix and the helix were fusing, particularly in this area, pulling the ear together and making that slit like ear entry. And that is what you need to look at for Mozart's ear. You will see that here the ear opening is The Simba concha is nice and big, but here you can see the Simba concha is collapsed because the antihelix and helix are fused with each other, bringing it more anteriorly. In Stahl ear, there is a problem over here in the scapha because extra crux. Bat ear is poorly developed antihelix, making it look like a cup. This ear is also important over here. We are seeing this is called as a Widermuth's ear. Widermuth ear. All right. Here it is the opposite. Here the helix is poorly developed. In bat ear, the antihelix is poorly developed. But here you can see this part over here. You can see that it is not curved. It is not curving like that. It is flat. It is like somebody has held the ear and it is doing it. KK is asking, then there will be conductive hearing loss. Alva, sir. Conductive hearing loss in Mozart, there will be, but see, the thing is, this problem is only there externally. The rest of the ear canal, the bony canal and the cartilaginous canal will more or less be normal. So the conductive hearing loss will be not very prominent, and that goes to prove that he was in fact a good musician, so he was able to hear his singing and sounds quite well. Most of these are only physical and appearance based problems, and functionally they don't have much issues. Okay, so Widermuth's ear, you have a flattened thing like as if somebody is held the ear and is pulling it. Now the next two images, they are very commonly asked and they can be confusing. That's why I have put them next to each other. In some people, almost I think especially in the Indian population, you can see more than 40% of the population in India have this thing called as Darwin's tubercle. Darwin's tubercle. Okay, this Darwin's tubercle is believed that it is a sign or a memory of that we have evolved from primates, because you see these monkeys, they have this little bit of a pointed thing like this. This has been debunked. Okay, so scientifically there is now no proof or evidence that is saying that this is really a sign of that, but because it is a small broadening in that area of the helix, Darwin's tubercle is asked sometimes in the exam, and it is especially given as a differential diagnosis to the next image. Now this image is an important clinical image that you can see over here. You see a whitish bead like structure over here on the helix, and you guess what this is. And this bead like structure may be multiple, 2 or 3 around this area. This is Gouty typhi or Gouty typhus. It is basically a collection of your uric acid crystals. So the patient will have an important history over here. All the other ear deformities, there is no history clinically other than a lack of appearance. But in this, you will have a history of joint pains and maybe some history that they are taking allopurinol or something like that. Okay, so which is so history of allopurinol, joint pains, having similar lesions and other places. Yeah, so drug of choice is saying because of the pressure also there is going to be pain and necrosis because cartilage has very poor blood supply. All right, so these are at least repeated, I would say in the last 10 years they have been repeated at least twice. Especially the bat ear has come, and Gouty typhi has come. Stahl's ear has come once, Mozart has come once, Widermuth is highly expected. Okay, now this is another question that guys commonly asked, especially for a visual image. There will be history of trauma, especially punching or some boxing or something like that, trauma to the lateral part of the face. This leads to oral hematoma. Okay, this is a hematoma. Hematoma will have a very acute history. That is important. Okay, acute history. And what you have to see over here in this image is that there are no ups and down bumps like you can see in the image number B. In this second image, you can see that there are bumpiness. All right, whereas in the first image there is no bumpiness, because a hematoma is acute. It has happened within a few hours, and there is blood that is collected between the perichondrium, and boxer ear, your drug of choice is generally the stage when it reaches B. That is also called as cauliflower ear. Okay, cauliflower ear. And here there is usually some confusion. People think it is the same. Cauliflower ear, boxer ear. All right. The difference is that from A to B, B is a complication of A. Okay. This takes certain amount of time to happen because this involves pressure necrosis. There is pressure necrosis occurring over here. So a poorly treated oral hematoma will lead to a cauliflower ear or boxer's ear, where you see these kind of ups and downs that are there, giving the shape of the cauliflower like appearance. And this is where examiners sometimes trick, because what happens in cauliflower ear, there is ischemic necrosis. Treatment wise, you have to do a corrective surgical repair, whereas in hematoma you have to do an incision and put a drain and give antibiotics and all of that. So management wise as well as presentation wise, they are different. And there will be more acute history of trauma in auricular hematoma, and there will be a delayed complication of forming cauliflower ear or boxer's ear when this hematoma has started to cause a lot of pressure necrosis onto the cartilage. Okay, so that's why this is an important differentiator. Now these three images look similar. They have been asked numerous number of times, especially A has been asked many times, B has been asked a few times, C has also been asked many times. Not much confusion in C. I'm sure you know already what C is, but A and B sometimes you get confused and it looks very similar. Can you tell me the difference between A and B in terms of the images? Archit is saying battle sign first, so that is correct. Why second one is not battle sign? Why is the second one not battle sign? Yeah, Grisinger is B, so that is correct. This is mastoiditis. See guys, these image based questions, the examiners will give you one or two history points that you need to come with. Those history points you'll be able to confirm just by the image. Many times things can be confusing, like many of you have written, Manish, Kavi, all of you have written the correct answer, so you are not confused with this, which is a good thing. A battle sign, what you have to look for is there will be history of trauma. So here there will be history of trauma, and you can see these, you will see bruising. Okay, bruising will be seen over here. That's a very important sign to say that there is actually trauma, and there is bruising, and there is a fracture of the middle cranial fossa causing the this kind of image. But what you see over here, Grisinger, is there will be history of middle ear infection because it's a complication. There's going to be middle ear infection, and there will be history of fever because this is lateral sinus thrombophlebitis, and that lateral sinus thrombophlebitis starts causing this bluish. You don't see any bruising over here, so there will be no bruising. Okay, you will see this little bluish color discoloration behind, and in mastoiditis you'll see a very ironed out crease. You won't see the post auricular crease. It's ironed out. It's a child, and there is an acute pain, and there is history of recent infection. So B and C will give an infective history, and A will give a history of trauma. So fairly straightforward, but to keep in mind and revise this. All right. Now another condition in the ear canal, as we are going, these look similar, but there is a difference between A and B. Okay, can you tell me what is the difference between A and B over here? Yeah, KK, it's called ironed out because when you iron something, the creases of the shirts and clothes go away. And there is a crease over here behind the ear called as the post-auricular crease. That crease cannot be seen. So normally you will see a very clear crease like this behind. But now you cannot see the crease because it is stretched out. So that's why it's called ironed out appearance, and that crease is not there. Okay, so we got Chota Doctor saying this is DNS. We are still in the ear, and that's why I'm saying sometimes ENT images look very confusing. So the history will give you some amount of things. So your drug of choice is saying Fungal. Yes. So this is the thing. Both are otitis externa. Okay, but this is local localized otitis externa. This is a diffuse otitis externa. Presentation is slightly different. Treatment wise, there is not much difference, but here you will see a very clear furuncle, pus pointing, or you may see frank pus also, and there will be history of some sort of injury. Put something in the ear, cleaning, and all of that. Okay, so this, in this case, your tragal sign may be plus minus. Okay, it is not very characteristic. The tragal sign, when you press the tragus over here, cartilage, and you push, patient should wince. That is not very characteristic in localized otitis externa, and there will be a history of trauma, injury, and there will be some pus of furuncle. Whereas in diffuse otitis externa, you will have a very positive tragal sign, and this is also called a swimmer's ear. It has happened once that the examiner has given both localized otitis externa and diffuse otitis externa in the options while asking for which is swimmer's ear. So you should know that not every otitis externa is swimmer's ear. The cause is different. Localized, there is some injury to the hair follicle leading to folliculitis or a furuncle, whereas in swimmer's ear, it is because of humidity. It's because of water getting stuck inside or remaining wet. That's why swimmers who swim for a long period of time develop swimmer's ear. And like somebody has written over here also, I think, yeah, 𝐒𝐿 is written, it is also called as Singapore ear, it is called as tropical ear, it is called telephone ear, a lot of things. It is caused, causative organism also is different. So in diffuse otitis externa, it is Pseudomonas, like drug of choice has written. In other one, it can be Staphylococcus aureus. So the treatment regime also changes. Even malignant otitis externa, it is Pseudomonas. So there are many theories that believe that chronic repeated diffuse otitis externa is leading to it. Chota doctor has suffered from this because of Q-tip trauma. Chota doctor, it is not a very easy way to do this, but it's a very painful way to remember this condition for life. But it's a life lesson, and which can get you some important points in your exams. Okay, so swimmers, Singapore, tropical, telephone, many words for the same diffuse otitis externa. Okay, this is Pseudomonas, not even a real monas, and this is staph. Okay, so gram positive, so you give more of amoxicillin, that kind of thing. Here you'll give a little broader spectrums, cephalosporin, along with a wick that is placed inside, could be medicated, and then follow up and keep ear dry in the second one. Okay, now looking inside the ear, we see two other conditions. We see otitis externa. Now we are looking at fungal infections, and here you can see two common fungal infections. Now, which is the most common fungal infection in the ear? This is asked. Whether is it A or is it B? Which is the most common fungal infection? Most common positive organism for otomycosis. Yeah, this is Aspergillus niger. This is Candida albicans. Yeah, so all of you are getting these answers right. See, most common is Aspergillus. Okay, most common fungal infection that we see in clinical practice is Aspergillus. Most common fungal infection asked in the exam is Candidiasis, because this has got a 𝐒𝐿 white. So you know 𝐒𝐿 white, and somebody has written wet newspaper paper appearance. See guys, earlier days there were no cameras, no endoscopes like this. People, you had to describe to others, so they would make it look like wet newspaper type, so that people can remember. Yeah, so Archit, voriconazole, or fluconazole, any of the antifungals nowadays, the treatments are very much based on evidence based. But here this is aspergillosis. In A and B is candidiasis. Common symptom is itching. Okay, itching is going to be your hint word. And aspergillus and mucor, many times people compare, though mucor in the ear is not seen. Mucor is largely seen in the nose. It is a commensal inside the nose. So Arshit, yeah, voriconazole is the drug of choice at the moment, but some books still say fluconazole. So we will leave it at that. I don't expect your examiners to ask anything which is of dispute. All right. In aspergillus, you will see, so this thing about septate and aseptate hyphae. Okay, so what is this septate? Many students get confused. They say septate is branching. Septate is not branching. In aspergillus, the septate basically means these lines that you see like a bamboo. All right, and it branches out acutely. Okay, so it's acute. Acute is not like this. It will be a little bit more acute, right? It will be acute, less than 90 degrees. All right, whereas in mucor you will not see any septate, and it will be a very 90-degree or flat branching. Okay, side branching, and that's how you can differentiate on your histopathology. Okay, now here are some very common looking images that have been asked a lot. All right, so let me see if you guys can crack this. What is A, B, C, D? Let's see if you can get all of them. What is A, B, C, D, and E? Yeah, so Chota Doctor, your drug of choice, everything on mucor and aspergillus that you're saying is correct. Now coming to this slide, what is A, B, C, D, and E? A, B look similar, C, D, E look similar, where sometimes you get confused. Okay, A is ear wax. What is B? D is surfer ear. D is surfer ear. Okay, we'll come back to that, Kavi. Whether D is surfer ear or not. What is B? Kavi is saying E is bullous myringitis. Okay, let's wait for everyone answer. Chota, E is glue ear. All right, guys, so here you're not getting these correct, so I'll walk you through it. All right, I think what we can see is ear wax is what all of you have gotten correct, and there is some confusion in the others. Okay, ear wax will typically, the hint for ear wax is you see a little bit of these hair, you'll see a little bit of hair follicles, you'll see a little bit of this light brownish to little black brownish. It'll look a little soft and it will look wet. Whereas this one over here is keratosis obturans. This is asked many times. In fact, this is the same image that has come from your PYQs. So keratosis obturans, it is all a history. They will say it is extremely hard wax. It's keratin. It is basically dried up skin. Whereas ear wax is cerumen. Okay, it is produced by the the cells there near the hair follicle. So it is much softer. But keratin is hard. You have to surgically remove this. And patient will have more pain, very painful condition, and conductive hearing loss in this particular scenario. Now the other three look similar. Now see, how do you differentiate between the three of them? See, when you see multiple white, so multiple, okay, this is a clue. When you see multiple white swellings in the ear canal, and plus there is history of entering cold water, this is called exostosis. Gets very confusing to osteoma. Okay, exostosis is where you will have multiple white cold water exposure. That's why this was also called as the surfer's ear, because Indians were not who started doing surfing. We have warm water. Surfing was usually done in the Pacific Ocean, which is very cold water. So people used to spend a lot of time surfing. Cold water started causing some inflammatory process to the bony structures, and it started causing this multiple bony growths, which is an inflammatory growth. But like Kavi, I think, has said, or somebody has told correctly, I think your drug of choice said D is an osteoma. The osteoma is very rare and they are usually single. Okay, they're usually single and they will not have any presenting complaints or history. That is what you need to remember in the word. So there are going to be clues in the question, and a single white swelling coming from the external auditory canal and no complaints, slow growing, is most likely osteoma. In exostosis, you will see multiple, you will see history of cold water, exposure or surfing, they may put it. What do you see in the last over here? Here you can see that the tympanic membrane is intact. This whitish swelling is not coming from the ear canal. Here you can see this is coming from the ear canal, this is coming from the ear canal, this is coming from behind the ear canal, and this is just to give you to perspective that this is a congenital cholesteatoma. Okay, this one is a congenital cholesteatoma. So congenital cholesteatoma appears, like this, pearly white with intact tympanic membrane, usually seen in a child closer to the, pars flaccida, but here it is there in the anterior superior quadrant. It's a congenital cell rest. It can be there anywhere, and the intact tympanic membrane, no previous history of middle ear infection or ear disease. And this is usually an incidental finding. There is no discharge, no scanty discharge, no typical CSOM symptoms over there. But this image, each of these in the lower row can be your differential diagnosis for any of the images. All right, so that is something that you need to understand. Now, what is this? This is the normal tympanic membrane. We are going to the tympanic membrane. I want you to tell me which is the right side and which is the left side. Okay, this is the normal tympanic membrane. Side is important to determine. In real life, we never have this problem. Patient is in front of us, we know which side we're examining. But here in this case, they give you an image. So can you tell me which is the right tympanic membrane and which is the left tympanic membrane? Okay, there are basically three things that we have to see. Okay, there are three things that we have to see to know. So there's some, let's see. Okay, some people are saying A is right. A is right. Okay, and B is left. Any confusion there? First right, second left, cone of light, sir, only image based in this live session. Yeah, Manish, image based, because 80% of the questions are coming image based, and we are doing the images from ear, nose, throat, head and neck, and in between we'll be discussing some important theory points. So you will get to see all the possible potential image based questions that can come, because no other platform or source is giving all the images together, and we have taken effort to collect all of them from your PYQs and all the potential questions that can be asked, so that you have a higher chance and you don't waste much time in ENT questions and get them right. Because as you can see, many of them you are getting right, but some you're getting confused, and the idea is to clear those confusions. Okay, so all of you are getting this correct, right and left. Now see, cone of light will point anteriorly. Okay, cone of light will be anterior, so that is an easy one. But many times when there is a perforation, cone of light will not be there, and when cone of light will not be there is when your confusion starts. Now the most stable anatomical marker which will be there, which will be pointing anteriorly, you can see it over here. This is the short process or lateral process. It's the same thing, of malleus. This short process or lateral process of the malleus is always pointing anteriorly, and this part of the bone does not get destroyed easily. It will be there even if you see a total perforation or a subtotal perforation or a large perforation with disease. You will be able to see this bone in most of the cases, and you will be able to tell whether it is a right ear or left ear, because just like cone of the light, you will be able to see, like drug of choice is saying, follow the malleus. You can do it. And if you want an illogical way, दिमाग नहीं लगाने का, what is this short process, lateral process, cone of light, then just draw one line in the middle, and your right ear will form an R and left ear will not form an R. तो tension नहीं लेने का है. But otherwise, short process of the malleus and the cone of light are two important things. Now, if you go a little bit more advanced, especially when there is tympanic membrane perforation, you will see two more structures. Anteriorly, you will see a hole like this. Posterior, you will see a hole like this. These two shadows are very important to also tell what is anterior and posterior, because anteriorly you will see the eustachian tube opening, and posteriorly you will see the round window niche. Okay, And these are also two important guiding structures to tell whether right and left. If the examiner gives you options where right and left options are there also in your MCQs, and it is a fully perforated ear, then and you're not able to see the short process of the malleus, then the eustachian tube opening will be very much anterior, and the round window niche you'll be able to see fully in the posterior superior or little bit at the border of posterior superior and posterior inferior quadrant. Okay, so now we're going to see many tympanic membrane images, so I don't want any confusion in the sides. Okay, now let's see this. What is A, what is B, and what is C? All three are commonly asked. Okay, especially B. B is asked the most. There's almost a question on B every exam, some way or the other, because it is so common. Even in our practice, we see B a lot. A is also common. C is also very, very common, but not frequently asked. But I am just telling you what it is. Archit is saying B is serous otitis media. So Archit, you are correct. What you're seeing over here, you're seeing these bubbles, right? So these bubbles, and it is not infected because it is maintaining the same color of the middle ear. So it is not, if it was yellowish color or greenish color, you would not see the bubbles. It would be similar to the image A. All right, but here you can see that this is clear. So this is called serous otitis media, secretory. Many names are given by different doctors. We follow all of them because we don't want to hurt anyone's emotional sentiments. Otitis media with effusion, glue ear. Basically, if there is no infected material, this is what it is, and this is the one in which you put the grommet. Okay, you put a grommet, you put a tube. I'll show you a video or an image with a grommet. Generally in the anterior inferior quadrant, you will put that and appear. Now, legendary 𝐒𝐿𝐼 is correct, and as well as Pratibha, drug of choice. All of you are correct. A is ASOM, and this is the stage of the cartwheeling appearance. There can be two types of cartwheel images that can be shown. I have one more image of a little bit earlier stage, because cartwheel is usually seen in the presuppurative area. Presuppurative stage, whereas it basically means a pus is just about to form, but it has not discharged. It has not come outside, right? So here you can see this streaks of blood vessels and this bulging out, and in those kind of days, those time people used to have bullock carts and carts, so that's why cartwheel. आजकल के time पे होते, then this would be like a Ferrari car tire or something like that, but unfortunately we were born very late. So this is the cartwheel appearance. Okay, very commonly asked. And surgically here you will do a myringotomy. Okay, you will take the posterior inferior quadrant and you will make a curvilinear incision here, whereas here in the anterior inferior quadrant you can see the short process of the malleus. This is the right ear. You will put a grommet over here. Why posterior inferior quadrant? Posterior inferior quadrant is most dependent even when you are lying down. Okay, so and you make a curvilinear incision because you want the hole to remain open till all the pus comes out. Yeah, and legendary 𝐒𝐿𝐼, you are right. C is a retracted tympanic membrane. It does look like bulbous meningitis, but bulbous meningitis, as the word meningitis says, it will be red. Here you can see the tympanic membrane is pale, pearly pale color as it is described. But what you are seeing is a retraction. How do you make out a retraction? You will see a much more prominent short process of the malleus. This is called foreshortening of the malleus handle. The handle looks, it has become shorter because it is pulled a little more, and your cone of light is distorted. Cone of light being distorted. So there are gradings of retraction of tympanic membrane. There's this guy called Sade, who's done Sade's grading. There are 4 or 5 gradings of tympanic membrane. First one, grade 1, is where just distortion of cone of light. Then there is foreshortening and more prominent malleus. Then there is completely adherent to the promontory, atelectic and adhesive. So there are 5, and the top part, pars flaccida retraction pocket, is by a guy called Toss. Somebody is asking a question, Kavi, what incision are we giving? Anterior inferior quadrant. So Kavi, in ASOM, when there is sometimes infection, for immediate pain relief, we make a curvilinear incision. This is called myringotomy. It is done in the posterior inferior quadrant. Okay, it is curvilinear because you want to cut through the radial fibers so that it doesn't close very quickly, and for 4 or 5 days all the pus can come. Whereas for B, which is grommet, which is for secretory otitis media, glue ear, you put the grommet in the antero-inferior quadrant, because there is no important structure that is there, because there is a physical piece of Teflon or silicon going inside, which is going to be the tube that will remain there for 6 months. So you don't want it to interfere with structures posteriorly. There is the all the structures are going posteriorly, right? They're all going towards the oval window. So there is the incudostapedial joint, and then there is the chorda tympani nerve. There are a lot of them. So grommet versus radial incision in serous otitis media indication. Archit, we will not do grommet, and in serous otitis media we will make a incision which is radial, because you want to put in the grommet, whereas in myringotomy you will make a curvilinear incision in the posterior inferior quadrant. So that is the difference, and this is a lot of questions come around this aspect. Okay, now here are some more images. These are taken from my camera, so just to give you some more varieties of what is A, B and C. Okay, so A is a freshly injured ear. This is a patient who came down from an aircraft after having barotrauma, and this is an increasingly new problem, because we are flying a lot and going scuba diving, and what happens is, whenever there is pressure related perforations, they are very common to see in this part, either the anterior inferior or posterior inferior quadrant. Whereas traumatic perforation, like you can see rugged edges, there will be history of physical trauma here, and you will see the rugged edges. Whenever there is natural disease, you will see a very circular perforation, but whenever you see this irregular edges, there will be something. This is a child who put a pencil inside the ear and caused rupture. And C is not cholesteatoma, because it has to be pearly white. This is just to confuse you. C is actually a glomus tympanicum. Many of the students, they think that glomus tympanicum and glomus jugulare are the same. They are actually not the same. Glomus tympanicum is coming from the promontory. It is coming from the, like the promontory is the medial wall of the middle ear, and sometimes a tumor from the blood vessels from the jugular the glossopharyngeal nerve plexus, which is there, it can come. Whereas the rising sun sign will be seen in glomus jugulare, which will always show that it is coming from the inferior hypotympanum area. So this is just to show that glomus tympanicum, if you see a mass like this, vascular mass that is there behind the eardrum, then glomus tympanicum can be there. Legendary Ritwik, perforation due to a slap in the ear. If there is perforation due to the slap in the ear, you will see a very clear radial kind of a tear, because it is usually a tear because of, you take a drum also. If this is an ear drum is compared to an actual drum. If you take a drum and hit it hard, it will make a straight tear. But it will not have too many rugged edges. It may be similar to the barotrauma image also, but barotrauma image is just a pressure leak, so it will be a very tiny perforation. But this is, just to give you a sense of certain images that can be asked. All right, now here these three are all different, all right, but they look very similar, same but different. Okay, so A, B and C. Here you can see, whenever you look at suspected glomus tumor, now glomus tumor, whether it is glomus jugulare or glomus tympanicum, is by looking at its inferior border. If you cannot see here, we cannot see the inferior border. It's not possible to see the inferior border, because the glomus jugulare is coming from the hypotympanum. So rising sun sign is in A. This is the rising sun sign. Here you can see glomus tympanicum is written because you can see the inferior border. If you can see the inferior border, it is not coming from the jugular floor. Okay, so this is a very important minute detail which can confuse you, because Glomus jugulaire is coming from the jugular fossa, jugular bulb, but glomus tympanicum is coming from the nerve plexus on the promontory. It is not coming from the jugular area. So you need to know that these are two different things, and what we see as clinicians is whether we can see the lower border or not, because the clinical features and treatment for glomus jugular and glomus tympanicum are different. Okay, here you have you'll have 9th, 10th, 11th, 12th nerve involvement, whereas in glomus tympanicum you will have 7th nerve involvement. Okay, facial nerve will be involved because of the different locations and the penetrations. And like Kavi has said, C is not glomus. Drug of choice, somebody has told correct answer just now. Legendary Ritwik, Schwartz sign, you are right, the C is Schwartz sign. This is the flamingo pink appearance in the posterior superior quadrant. Okay, posterior superior quadrant, you can see the flamingo pink appearance. Posterior superior quadrant. Otosclerosis is actually otosclerosis because it is seen only in the active stage of otosclerosis. Okay, that's why it's spongiotic stage. There is blood supply around the footplate of stapes, and the footplate of stapes is there in the posterior superior quadrant. Many people think in flamingo tympanic membrane the entire eardrum becomes flamingo. No, it will only be the posterior superior quadrant. You can see the eustachian tube opening very nicely over here, cone of light, everything is fine, but in the posterior superior quadrant you can see this slight change of pink color. In this case you do not do any surgery, you give sodium fluoride. Okay, so you give sodium fluoride treatment, and what sodium fluoride will do, it will convert the spongiotic bone into sclerotic bone, and then you can do a stepedotomy. Okay, but it's important for you to understand minute differences and look at the history, pick some important words from there and confirm your answer. All right, now here there are two images. One is a repeat image, other one is also an extension of an image. All right, this is what I would call as a grade 4 or severe retraction. You can see the eardrum is fully plastered on the promontory. You can see all the structures of the promontory. All right, so this, in the structures of the middle ear over here, you can see the incudostupidial joint, you can see the promontory over here, you can see the eustachian tube opening over here, round window niche there. So all of these structures you can see, and this is your congenital cholesteatoma, which I put before also. All right, so get used to these images. Congenital cholesteatoma. Okay, yeah, grade 4. Drug of choice, TOS will be pars flaccida. In this image we cannot see pars flaccida. In A I cannot see pars flaccida right now. I can see pars flaccida here, but here the image is such that you're only able to see the pars tensa. Okay, pars tensa retraction is by SADE, and TOS is for pars flaccida. Okay, now here are some other conditions just to make you used to it. Now I'll move a little more faster because we have to do nose and throat as well, and head and neck, but you're getting the hang of this. This A is also very commonly seen, and it is not a very abnormal disease condition. This is called tympanosclerosis. Tympanosclerosis is calcium deposition, usually seen in old age, and it presents with very mild conductive hearing loss. Nothing needs to be done in terms of treatment. It's just basically scarring. It could be a healed tympanic membrane or just some calcium deposition. This over here you can see is a subtotal perforation, and here are the structures that can be asked for you to be marked in your exams. Okay, so this is the handle of malleus. You can see handle of malleus. Right, now can you tell the side in this? This is, you can see the short process of malleus, right? So this here you would see the eustachian tube opening. We cannot see right now because the annulus is intact, but otherwise here you would see the eustachian tube opening. This is the promontory. Promontory is nothing but the basal turn of the cochlea, and here you can see this green arrow is the incudostapedial joint. This over here is the round window niche. You can see a bit of the stapes here, right? And then that's why the oval window is over here in this part, and that's why in the posterior superior quadrant you will see this kind of flamingo pink appearance, which is in otospongiosis. That is the area where there is blood supply. So this image again is another Schwartz sign. All right, so I think now you're fairly used to these images and these structures, so I hope you will not have any confusion in picking these in your exams. All right, so another Schwartz sign over here. I'm just showing you multiple varieties of Schwartz signs so that you do not get confused. Here this is another variant of the cartwheel appearance. You can see a little bit of these blood vessels over here, right? So this is all patients can come in any stage. Patient textbook पढ़ के नहीं आते. Sometimes it look exactly like what we see and we call it textbook appearance. Sometimes it will not be there. You have to take from the history. People are taking antibiotics. Presentations are not always very accurate. Okay, so this is how you can see it. What is this this part? What is this that we can see over here? Multiple perforations. This has been asked once I think it was. When you see multiple painless, here's the clue: multiple painless perforations. Right? This is tuberculosis. Okay, so this is the TB, tuberculosis, TB here. Pratibha is saying correct. Legendary Ritvik is also saying correct. Tuberculosis, most places will be very subclinical, will be very mild. If it is a traumatic perforation, you will not see such smooth edges. Okay, these edges are very, very smooth. So they are basically because of long-standing some granulation tissue as well. All right. If it is traumatic perforation, you will see rugged edges. Okay, here there are clean edges. The only place in ENT where tuberculosis is painful is tuberculosis of the larynx, which I will show you. I have an image of it. There's a typical rat nibbled or mouse nibbled appearance that you can see, and it is extremely painful. All other conditions, tuberculosis is not painful. So being painless is the clue over here, and this was a question that was asked in your PYQs as well. All right, now this is of course very important topic. It's a very long topic when we discuss in our theoretical chapter. So guys, I'm moving fast because I will show you a lot of images, but anytime you want to go deep dive, go to the main videos of these and you will see this is your unsafe ear, or which is nowadays called as squamosal chronic otitis media, or this is atticoantral, the old nomenclature. Right, you can see that there is attic disease, and this is how your typical cholesteatoma will look: scanty, blood stained, very foul smelling. If you have ever smelled the bony decay of the ear, you will of cholesteatoma, you will never forget it. And this is not a disease to have an experience like you did for furuncles, but this is a disease that is very common, especially in India, because of a lot of swim ponds and overcrowding and poorer immunity, and leading to repeated infections. And there are many theories of cholesteatoma: retraction pocket theories, migration theories, all of that in great detail I have discussed in my videos. So if you want to deep dive into cholesteatoma, you can do that. Otherwise ये इधर ही 1-1.5 घंटे का chapter बन जाएगा, which I think is not the purpose, is to help you revise. I know you've already prepared and you were ready for your exams. Okay, now here there is another image, A and B, to come with the end of our ear images. All right, let's see, video is lagging. Okay, slight bit of rain in Bengaluru over here, so the internet is slightly fluctuating. If the video is back, let me know on the comment section if now the lag is gone. All right, A is commonly asked. This is malignant otitis externa. Okay, and B is a bug in the ear. Yeah, so this is an insect in the ear. All right, so both of these are asked quite a bit, especially malignant otitis externa is very important from standpoint, you see this granulation tissue, typically elderly with type 2 diabetes mellitus and chronic non-healing. It's an otitis externa with some local invasion. Malignant otitis externa is very important question caused by pseudomonas, right? Whereas in the insect in the ear, they will ask you usually what is the first line of action that you would do when you see a patient with insect on the ear, and your answer would be to kill it, kill the insect before removal with turpentine oil. This aspect has been asked because you don't want the insect to create any injury while you're pulling it out, and you can pull it either surgically or through sort of piece. So if it is a small insect, you can flush it, and there are many ways to remove it. So turpentine oil is used, which is some porchlorhexabenzidine, something like that. But turpentine oil is what you would for this. All right, now some quick radiography. So for mastoiditis or mastoid disease, there are two views that we will see in the ear. One of them is a Sculler's view, which is the common view that we see. This is Sculler's view. And this angle that you can see is called as the Citelli's angle. It is a sinodural angle. It is very acute. Generally, if there is a sclerotic mastoid, and it will be obtuse when the mastoid air cells are well aerated. All right, and this view below you see is the Law's view. There is not much difference between the two other than a 15-degree angle. Cephalocaudal matlab front to back. Cephalo is top and caudal is back, so that is the angle that is using. But this has been asked one or two times and is more commonly also to be asked because of more cochlear implant surgeries being done. Which X-ray view will you see the positioning of the cochlear implant? And that is the Stenver's view over here. You can see this is the Stenver's view, and in Stenver's view you can actually see the electrode wire coiled inside the cochlea very nicely, and this is at a 45-degree angle. Petromastoid, which is antero-oblique. Okay, so petromastoid or antero-oblique appearance. So if because I'm seeing a recent trend, at least in the last 3 consecutive exams, cochlear implant related questions are there, and more cochlear implants are expected to happen in future when you guys come out as doctors. So I think the examiners are going to ask something about cochlear implant, and then this is a low-hanging fruit that they can ask. It's a image-based question on which X-ray or radiology for looking at the position of the cochlear implant. That would be the Stenver's, right? Now, this is a CT scan of the temporal bone. I will not go into much details over here. Temporal bone is hard to read even by many ENTs. It takes some time. So please clarify. Lydia is asking, it was given that croup presents with inspirator stridor, but MCQ practice biphasic stridor, which is right? Lydia, I have just in the next couple of slides an image on croup, and I will answer that question. Okay, now in HRCT temporal bone, this is the thing that you need to see. You see this ice cream cone appearance over here. This is the malleus. Okay, so ice cream cone appearance, malleus. Now, other thing structure that you need to be able to see very clearly is this over here. This is the cochlea, and you can see that the cochlea will be seen like a clover leaf. These are the 3 coils or the turns, and this is the one that you need to see. Sometimes twice this has been asked in different ways. If the cochlea is not there, cochlea and semicircular canal is not there, there is a condition called as Michel's aplasia. And if instead of the 2 and 3/4, so we have a 2 and 3/4 turn of the cochlea, right? 2 and 3/4 turn, right, of the modulus. If this turn is not 2 and 3/4, it is less than that, then that is called as Mondini's dysplasia. So in that, you will only see maybe just 2, or you may just see 1. and that is what is asked. Okay, so Michel's aplasia is where you will not see the cochlea being present at all. In fact, the entire labyrinth may be absent. In this particular case, Mondini's dysplasia, you can see this, the cochlea. So for you, from image-based perspective, you need to just focus on these two structures. One is this ice cream cone appearance, which is showing the malleus, and this clover leaf shape. You can see this side, if you focus on this side, you can see the clover leaf shape much more nicely, and that is where you need to look for the cochlea. Or so that is there. All right, now let me answer your question, Lydia. In biphasic stridor, when croup is happening, it's laryngotracheal bronchitis. You should remember one thing, that when the obstruction, so let me say glottis, if the obstruction is above the glottis, it will always be inspiratory stridor, because that is the first obstruction is when you are inhaling the air. So in any glottic problem, like a laryngomalacia, epiglottitis, anything above the glottis, there will be inspiratory stridor. And if it is below the glottis, then the stridor is during expiration. So if it is below the glottis, it is expiratory. Above the glottis, it is inspiratory. Now what happens in laryngeal croup is it starts above the glottis and then extends to the subglottic region. So the classic presentation is patient presents with inspiratory stridor that progresses to a biphasic stridor because of the involvement of the glottis and the subglottic area. So that is why it is just basically a different stage of the disease. Early stage of laryngeal croup will be inspiratory, but by the time you see that people sign, which I have an X-ray image of, you will see biphasic stridor at that point of time. Now here, two important, I'll remove this in your notes, you'll get confused. Okay, so two important pure tone audiometries. This is pure tone audiometries, and this is a very commonly asked. You can see a 2K dip. So like drug of choice has said, this is otosclerosis, Carahart's notch. Classical 2K dip, only in bone conduction. It's only in the bone conduction. It is not in the air conduction. But when there is a 4K dip at both air conduction and bone conduction, then that is noise induced hearing loss, also in ototoxicity. Okay, whereas if you are talking about presbyacusis, which is just sensorineural hearing loss, you will see this kind of sloping, like this kind of a sloping hearing loss will be seen in presbyacusis. So no confusion there. This is also very commonly asked. All right, now what is A and what is B? Okay, so A is basically nothing but tympanometry. Tympanometry is different from tympanogram. Okay, this is also called as impedance audiometry. All right, in this impedance audiometry, you can very clearly see A is normal. Okay, this is normal. What are we mapping again? So we have put a probe inside, we are changing the pressure. The pressure of compliance is measured in another mmHOS or Siemens, which is basically a measure of electrical conductivity. All right, and this is in decapascals, which is the pressure changes. A is a normal curve. You will see this AS, which is stunted or short A curve in otosclerosis. Otosclerosis is a star when it comes to questions and exams, so people will ask a lot. All right, yeah, drug of choice in pure tone audiometry, if there is an upsloping type of curve, then that is Meniere's. So put that here also. Initially it will be sloping, later on it will come back. All right, so now let's come back to this. This is where there is discontinuity, ossicular discontinuity. Also, a very important MCQ is asked after otosclerosis surgery, where you do stepidotomy. What is the kind of impedance audiometry you will see? That time you will see AD. Okay, AD is seen after surgery for otosclerosis. Don't think that after you do the otosclerosis surgery where you have done stepidotomy, it will come back to a normal. This has been asked twice in the last five or 6 years in multiple questions, that after otosclerosis, when you do stepidotomy, what kind of impedance audiometry you will see? You will see AD type, which is, D stands for deep, or it is also seen in ossicular discontinuity, because here the piston moves much more faster, much more deeper than the actual foot plate of the stapes. What do you see in B over here? B is nothing but a stapedial reflex. So whenever there is facial nerve palsy and you want to know which is the site of localization, whether it is the middle ear or not, then you do you give that same impedance audiometry probe and you give sounds. Like here, I'll just zoom in. You can see that at 85, 90, 95, between 90 and 95 you are seeing the stapedial reflex. Before that you are not seeing. So that means the threshold of the stapes reflex has increased. Normally you will see it at the 80, 85 mark. Okay, so they will not ask you what is it. So what about after TORP? Whether it is after TORP or whether after stepidotomy. See, after doing stepidotomy they put a prosthesis. After that you will see the AD type of impedance audiometry drug of choice. Okay, and this is to just recognize what a stapedial reflex graph looks like. All right, this A and B are also two common images asked. Questions are asked about both of them. It's very easy to differentiate. This is your screening of choice, otoacoustic emission screening of choice, whereas B is nothing but BERA or ABR. It's the same thing. BERA is brainstem evoked response audiometry. ABR is auditory brainstem response. All right, audiometry. Now here, how do you differentiate in a simple way? In OAE there are no leads and wires. Okay, there is just one probe over here that you can see, one probe going inside the ear and one small handheld device. That's it. And in its this thing also you will see it just dots will be there, because it is basically showing that when you gave one tone, whether you're getting a tone from there or not. So this is how this graph will look like. And here you can see it, DP means distortion product, means more than one noise is given. So otoacoustic emissions are of three types. One is spontaneous, where you don't do anything. Other one is where you give a single tone, and other one is where you give double tone, which is distortion product. So these three types, and then you look for the response. Whereas in BERA, you know that 𝐒𝐂 you must have a lot of people have made for that, so you will be able to know. Whereas that is wrong actually, because technically in BERA the 𝐒𝐂 is not assessed. Your auditory cortex is not assessed in BERA, and that's why a lot of students get this answer wrong. If the examiner just asks which of the following is picked in BERA, and they put the auditory cortex at the end, you will get it wrong, because BERA does not examine the auditory cortex. There is another test called SERA, which is cortical evoked response audiometry, which will be able to tell whether the auditory cortex is functional or not. The BERA is basically only telling up to the medial geniculate ganglion over here. You can see in this image also, they don't show a wave for the auditory cortex, right? And what is the most important wave is to see is 4 and 5, which is the lateral lemniscus. Okay, is the delay or latency in wave 4 and 5 is what tells us that there is this thing. So now somebody saying in ICU infants BERA or OAE. Anywhere the first drug of the first choice will be OAE. Now the problem with BERA is you need a soundproof quiet area, and ICU is actually quite noisy. So BERA is actually not very conducive to do even in the ICU. You have to shift the child and on the ventilator into a soundproof room and do it, because otherwise there's a lot of noise and this graph is not very clear. So as per clinical evidence of medicine, your first choice of screening will be for OAE. Now if they ask whether their patient with ICU has meningitis or some sort of intracranial problem, then the answer would be BERA. But otherwise it is going to be mainly OE, which is the thing. And I think let's just stick to that and not confuse, because in real life we take very different clinical decisions. Here it is your exam, so they will ask you what is very standard and what is done. All right. Now this is another area where people get confused. What is the difference between A and B? There are two main differences between A and B, and in terms of indication, in terms of its classification, in terms of what they are. Do you know what the difference is? So ear is the one which had more images. Nose and throat and head and neck don't have too many images. We'll be able to finish it very quickly. All right. Legendary Ritvik. B is Baha. Carpal tunnel. B is Baha. Yes, B is Baha. What is A? Baha is bone anchored hearing aid. All right. So here your hearing aid is anchored to the bone. There is usually no earpiece. All right. Whereas in a cochlear implant, you have the processor, transmitter, the receivers are all inside. Okay. So this is A is a cochlear implant. B is a bone anchored hearing aid. Now a question that has been asked numerous amount of times is Baha is not an implant. Okay. This is not an implant. Technically, no part of this is entering the cranium. It is only stuck to the skull. A titanium screw is there that is stuck. It is drilled into the skull, but it is not going through and through. In a cochlear implant, an electrode is going inside the cochlea. That is a proper implant. All right. But here, your bone anchored hearing aid is not an implant, and it is done, like legendary Ritvik is saying, in any time, in any condition where you cannot hear from the external auditory canal and the middle ear part is there. Like for example, there can be anoxia, microtia, atresia, all ossicles are not working, middle ear itself is not there, all of these things. If the cochlea is working, Baha will be used when cochlea is fine. Here the cochlea is normal, then only your Baha can work. But in cochlear implant, there is a cochlear pathology. You need to amplify it. All right. So that is the main difference between these two. Okay. Cochlear implant is an implant. Baha is not an implant. That is an important takeaway that you need to get. All right. Now here are some images of these prostheses. I told you in glue ear we put the grommet. This is what the grommet looks like. Okay. As you can see, this is in the antero-inferior quadrant. And this that you can see in image B is what the prosthesis for otosclerosis looks like. Okay. So there has been a stepidotomy done. Stepidotomy. And then there is this titanium Teflon prosthesis that has been put, that is hooked along the incus. Okay. So it is hooked along the incus and it is going into this. All right, lot of questions related to stepidotomy. Earlier we used to do stepidectomy, where we used to remove even the foot plate of the stapes, but that caused lot of vertigo and other issues, contraindicated in pilots, lot of those things. Nowadays we do stepidotomy. Dotomy means whenever a tomy is there, it is a hole. Whenever ectomy is there, it is removal. And whenever plasty is there, it is repair. It's just Greek and Latin. It's another language. If you learn that language, things become very easy. All right. So this I hope you understand. Now what is this, guys? This is a new thing, and this has been asked in different ways. This is what we call as VEMP, for evaluation of vertigo. This is called vestibular evoked myogenic potential, where we give a sound and look for muscle contraction. So whenever we hear a loud sound, we make certain movements. And why the neck movement is there? Because of the sternocleidomastoid. The sternocleidomastoid has a response to loud sound, and your eyes close, your ocular muscles have a response to loud sound. So what VEMP does, it has put electrodes, we put electrodes on the sternocleidomastoid and we put it around the eye orbit. Okay, and we look for either cervical, okay, and we look at ocular. All right, and basically the cervical one will tell whether your inferior vestibular nerve is fine, and ocular will tell whether your superior vestibular nerve is fine. You don't need to go into that detail, but if you see a fairly adult with electrodes on the sternocleidomastoid or around the eye, you can tell that they are doing VEMP, which is vestibular evoked myogenic potential, which in Greek and Latin basically means you are evoking the balance system and looking for the muscle contraction. And this is a new thing, so that's why it can be asked. So moving into nose is fairly straightforward, not too many image based questions like in ear, but by now you have covered most of the ear based questions that are possibly that can be asked. So I think you should be good with otology in terms of image based questions, graphs and all of that, even radiology. Now here some technical differences. This is a deviated nose. Okay, this is deviated because the tip is not in a straight line, but here you can see the tip is in a straight line. So this is crooked nose. Commonly asked. This is a saddle nose. This is a humped nose. Both will have history of trauma. In fact, all of them will have history of trauma, but this one is also known as boxer's nose, right? Because of the injury over here, and also then they develop septal hematomas and all of these. These are just very quick, simple image based questions. We won't waste too much time over here. All right, now we've got 3 images which have been asked before. Tell what these are. In the external image of the nose, these questions, all of them have been asked. The treatments are different, diagnosis are. What do you see in A, B and C? Yeah, this A is called vestibulitis. Extremely painful condition because of the infection of the Lyman nasi area or the vestibule area of the nose. If you've had this because of either a furuncle or picking the nose, history of picking the nose, or diabetes will be there. When as an ENT resident, our advice that was given by our superiors is anybody with vestibulitis has to be admitted and given IV antibiotics, because this forms a danger area of the face. Any infection from here can go through the ophthalmic veins into the cavernous sinus and cause a cavernous sinus thrombosis. So the danger area of face, the veins do not have any valves, so they cannot regulate the direction of the blood flow. So vestibulitis has to be treated with admission and IV antibiotics and close monitoring. But ऐसा कोई करता नहीं है, क्योंकि पेशेंट बोलते हैं यार ये फुंसी के लिए मेरे को एडमिट कर दिया. That is a different thing. बाद में मारने वो टाइम पे आ जाते हैं. But that is our job to explain the gravity of the situation, that something as simple as a small furuncle is in the danger area of the face, and there can be risk of cerebral infections, intracranial infections and cavernous sinus thrombosis. So consent लेके फिर भेजना. B is asked, guys. B has been asked, I think, just last year or last to last year. The most common site for any, you see this rolled out everted edges. Okay, this rolled out everted edges, you can see this is basal cell carcinoma. Most common site, lateral surface of the nose. So whether you will see it here, here, any lesion on the lateral surface of the nose in an elderly, slow growing, rolled out everted is the word, then that is basal cell carcinoma. This over here is a rhinophyma, potato nose. Because of the sebaceous gland hypertrophy, nobody really knows the cause for it, but it is a popular image based question, also known as Ompuri nose. All right, now this is what the endoscopic nasal cavity will look like. So sometimes they can just give you a normal endoscopic nasal cavity and ask you to identify certain structures over here. Can you tell me, guys, this is the right nasal cavity or the left nasal cavity? The right or left? I just want to see if the screen is not frozen. I don't see any comments. So is this the right nasal cavity or the left nasal cavity interaction? That I know I'm talking to a lot of images, I know, but we are going to wind up in the next 15-20 minutes. So not too many images left. We'll run through it a little bit more quickly. But just to tell you what are the important structures. Okay, so you need to know the structures over here. Is it Yeah, able to see your comments. Now I can see guy has. Yeah, A is right. So this is the right nasal cavity. This is also the right nasal cavity. How do you know? Okay, so this you have to see which is the flatter surface, guys. So this is the septum. Okay, septum. This is the inferior turbinate. This is the middle turbinate. Okay, this is also the septum. This is the inferior turbinate. This is the middle turbinate. Okay, what are the extra structures that you can see? Right. So here you can see this bulge which is not there over here. This is a very important agar nasi. This is the anterior most ethmoidal cell, agar nasi. If you punch into this agar nasi area, you will find the lacrimal duct which is opening at the highest part of the inferior turbinate. So for DCR surgery, which is endo DCR, dacrocystorhinostomy, we find the agar nasi and we use a Kereson's punch, which has also been asked in your exams, and we punch into it. You don't see an agar nasi cell over here, but I can see the uncinate process over here. Here in the first image A, uncinate process cannot be seen. So this is the floor. Okay, floor is very straightforward. Inferior turbinate, middle turbinate. We cannot usually see the superior turbinate, but this is to just orient you to what endoscopic views look like. All right. Now, what do you see over here, guys? We have three options over here. So let's go through this quickly. A, B. All three are different. What is it? Oh, A पे तो लिखा हुआ है, so there is no point asking. This is a nasal polyp. This is most likely an antroconal polyp. The antroconal polyp, history of allergy, one single large polyp which is there from the antral, antrum means the maxillary antrum and the choana going all the way back, right? So this is the antroconal polyp or an AC polyp. Whereas B, you can see that there are multiple polyps. So this is sinonasal polyposis. This number C has been asked so many times, guys. I have not seen it that many times in real life, but because it is an interesting question, inverted papilloma. Where it is the papillary structures, but they're inverted. They are basically penetrating inside. So that's why it is inverted papilloma. This exact image itself has been asked three times in NEET PG, and sometimes, the treatment wise, all of them are same. We do just press an endoscopic sinus surgery using a microdebrider. But image based, they asked inverted papilloma a lot for some reason. That's correct. So Ritvik is saying it's tumor. All right. So this is the difference. See, sinonasal polyposis, what you need to look at is you will find a lot of these polypoidal structures. Okay. This is basically another image of the inverted papilloma. So this is inverted papilloma. Sinonasal inverted papilloma, whereas this is your standard nasal polyposis. Nasal polyposis will be very pale and very fluid filled, whereas inverted papillomas will have some blood tinged, also slightly more darker in color, and they will have very irregular outer surface because it's going inverted. Its papillomas are inverted. All right. So this is a question that is asked a lot, even asked in this FMG exam that just happened a couple of days ago. This is A is an important question. B is normal, just to give you a reference, and C has a clinical finding that they can ask. All right. So A will normally be a female with merciful osmia and roomy nasal cavity. That is atrophic rhinitis. Atrophic rhinitis is like otosclerosis, a star question. कुछ ना कुछ तो आएगा, whether Young's operation or whether an image based question, or whether the signs like muscle cavity and all that. C is septal spur, drug of choice, and Ritvik, you're correct. Septal spur is very important because septal spur is a cause of recurrent epistaxis. spur is, so in DNS you have these S-shaped and C-shaped DNS, and then you have this spur which sometimes can be impinging on the septum wall. Okay, this is the sorry, this is not the septum, this is the septum, septal spur, this is the turbinate and middle turbinate. And they can, because the thinning of because of the thinning of the mucosa over the septal spur, it bleeds very easily and causes a lot of pain. Here you can see crusting. You may get confused with this as mucormycosis. Mucormycosis will be blackish crusting. They will give history of diabetes, they'll give elderly age, they'll give a COVID history, maybe all of that. But if they use the words like merciful anosmia, roomy nasal cavity, and you can see there is so much of space over here. This is basically thinned down so much. Look at the normal inferior turbinate, much larger, but see this inferior turbinate is thin. There is also septal perforation also, right? Commonly asked another question, guys. This is also, what is the difference between A and B? Can you tell me? This is also asked a lot. I picked only the commonly asked ones, especially the ones that are similar and look confusing. Okay, A is a septal hematoma, and these are inferior turbinates. Okay, this one is inferior turbinate. Okay, so how do you make out the difference in such an image? In septal hematoma, you will see that it is convex like this, whereas in inferior turbinate, it will be concaving like this, all right? Because inferior turbinate is coming from the lateral wall, septal hematoma is coming from the medial wall or the septum. B is not adenoid, drug of choice. Adenoids are in the nasopharynx. Here we are just seeing anterior rhinoscopy. I will show you what adenoids look like very shortly. Here it is just somebody who is going to undergo turbinate surgery, but because they look similar, I want to tell you, in septal hematoma, you're basically going to drain out, and you're then going to pack the nose, not for controlling bleeding, but to just stop the pressure and the pressure necrosis, and drain basically all the blood and give a course of antibiotics and observation, right? Whereas in turbinate, inferior turbinate, you can do turbinate reduction surgeries like a turbinectomy, turbinoplasty, or you can reduce it using coblation. Okay, I am quite interested to know if you can recognize what A is, because I know you have seen A image a lot, but you have seen it only in diagrams. I doubt if you've actually seen a real image of what this is. So I'll be quite pleasantly surprised if you can tell me what A is. Then we'll go to B and C. Okay, so take a good look at these endoscopic images. These have all been asked, unfortunately. So you better know what these. Okay, can someone tell me what A is? Waiting. Okay, comments. No idea. Juvenile nasopharyngeal angiophyma. Yes, so this is not this. First of all, what you are seeing over here is what we call as posterior rhinoscopy. Okay, you must have seen a posterior rhinoscopy mirror, no? That mirror which is like this, right? So this is what look it appears. In your Dingra and all of these books, they would have made some nice drawing. Okay, so now let me tell you what these parts are. We are looking from down, we're looking from below the palate to the back of the nose. Okay, so actually this image should have been ulta, but because we are seeing from reverse, this is the septum, this is the inferior turbinate. Okay, end of the inferior turbinate and the septum. Here this is the roof of the nasal cavity, and you see adenoids here. This is the nasopharyngeal wall. This is the eustachian tube opening. This is the torus tuberis. And the fossa of Rosenmuller. All right, so this is the quana. Now, when somebody has quanal atresia, and I'm going to show you images of child with quanal atresia. This is the image that they will show you, and आपको कुछ idea नहीं होगा, mind blown. But it would be very, very simple. Okay, it's posterior rhinoscopy. Anterior rhinoscopy is front. Posterior rhinoscopy is from behind. Now, this B image is your proper nasal endoscopy. Okay, this is your nasal endoscopy of the nasopharynx. instead of being in the front, I showed you these images. This is the image of the nasopharynx. This is the image of the endoscopy from the front, and when we go all the way back, this is the image we will get. This here you can see is adenoid, right? This is the right nasopharynx. You can see the eustachian tube opening over here, the eustachian tube opening. This is the torus tuberis, turban like turning, and this over here is the fossa of Rosenmuller. What cancer originates from the fossa of Rosenmuller? Okay, so this is the side for nasopharyngeal carcinoma. Okay, and this has also been asked many times. Even in this last FMG it was asked, previous also it was asked, and your INI-CET also, fossa of Rosenmuller is always asked. But this is what it looks like. You must have seen one image where there are two yellow circles. This is the image that you can see. This fossa of Rosenmuller is inside over here and behind the torus tuberis, so that's why it comes from this side. And if nasopharyngeal carcinoma goes laterally, it causes the Trotter's triad, right, which it enters a sinus of Morgagni. It causes conductive hearing loss, it causes neuralgia, it causes retroorbital pain and all of that, palatal palsy. Okay, now guys, this is choanal atresia. Okay, now you will understand after I showed you the normal one, choanal atresia, very commonly asked MCQ, but this is the visual. Here you see it is unilateral and here you see it bilateral. This side looks maybe bony and this side looks membranous. Okay, this is how it looks in posterior rhinoscopy, and the trick to know is by looking at the septum. The septum is what gives away anything that is in the middle, dividing into two, and you can see this inferior turbinate over here. That is how you will realize that what this is. And also you can see the eustachian tube opening. Okay, so those are the clues in terms of images, and you are looking from behind, so the camera is going behind and looking upwards. That's why the images are ulta. All right, now these two are very commonly asked. This one, A, is a celebrity, which is nasopharyngeal angiofibroma. You see this red, beefy, multiple bleeding in young male, adolescent male, whereas in this one you can see the nasopharyngeal carcinoma, which is bleeding, it's ulcerative, and it's coming out from the fossa of Rosenmuller. Like I showed you, the eustachian tube opening is here. This is the torus tuberis, and here is the fossa of Rosenmuller. Okay. Whereas nasopharyngeal angiofibroma, a lot of questions are asked in nasopharyngeal angiofibroma, almost always in male. Doesn't mean it doesn't come in females. It does come in females. I have seen a case where it comes in females, and when it comes in females, its first most common spread is into the maxillary sinus, but it is almost always in males. And the other questions that they ask, it originates from the sphenopalatine foramen area, anterior lip. Okay, and the sphenopalatine foramen area is right at the back of the middle turbinate, or behind the superior turbinate. So it is basically in that space called as a sphenopalatine area. Sphenopalatine foramen will be there in sphenopalatine area, and the reason why it bleeds is because of lack of contractile fibers, and that is the reason why it bleeds. You have to mobilize and do the surgery. In this particular case, nasopharyngeal carcinoma you will see in much older age group, and you will basically not do surgery in this case. You will do as your treatment choice, right? These are plain and simple adenoids. Okay, so these are adenoids, pale, looking like little clumps. So adenoids in the nasopharynx. Here you can see the left nasopharynx. This side you can see the right nasopharynx, because I am figuring out which side the septum is. Okay, septum, yeah, right. So no confusion. Coming to the oral cavity. Okay, now oral cavity, we have finished more than 70%, so another just 20-30% is left. Let's finish the remaining images, and I can go a little bit more faster for you because this is a little bit more straightforward. This is a normal oropharynx. Let's see what the structures are. Uvula, this is the anterior pillar, which is the palatoglossus. Other one is palatopharyngeus. Anterior palatoglossus, because coming to the tongue, posterior palatopharyngeus, and in the middle you will see the tonsils. All right, and this is the posterior pharyngeal wall. Very, very simple. Right now quinsy is not there. I'm showing you the image of quinsy next. This one is parenchymatous tonsillitis. It is chronic because it is not too red, it is large, and you can see these crypts. These are crypts, CRYPTS. They are basically depressions inside the tonsil, and food gets collected inside and you get repeated infection. Sometimes you might see white follicles. Okay, so if you see white follicles, then it becomes follicular tonsillitis. Okay, white will be follicular. Right, now here's a question asked many times. All right, so what is this A and what is this B, and what are they asked? Okay, so membrane tonsillitis, there are a lot of differential diagnoses, away from strep throats to infectious mononucleosis to cases. This one over here is a child with diphtheria. Okay, and you cannot scrape out, you'll cause raw surface and bleeding, so there will be bleeding on scraping. Okay, it is a pseudomembrane. It is a pseudomembrane, but it still bleeds on taking it out. All right, so diphtheria antitoxin has to be given. Myocarditis is an important complication, so the child should not exert themselves for a few months, otherwise they can have a sudden cardiac event. This question was asked, I think, in the last time's NEET PG, which membrane cannot be removed, and this is hairy cell leukoplakia. Caused by Epstein-Barr virus. Okay, so this hairy cell leukoplakia is in the lateral wall, and this is by Epstein-Barr virus, and this cannot be scraped out, so this should be fine. Now somebody was telling about quinsy, so this is an important thing. Quinsy, which of these is quinsy? Peritonsillar abscess, whereas this one is parapharyngeal. Now, a very important thing that you have to know is that in quinsy or peritonsillar abscess, they will say that the uvula is pushed to opposite side. Every question on quinsy, this is a standard word, uvula being pushed to the opposite side, and there is no neck mass here. Okay, this is very important. In parapharyngeal abscess, you will see a neck swelling. That is the main differentiator in terms of clinical presentation when it comes to parapharyngeal abscess, because it is the parapharyngeal spaces are very large, full of fat, so they get poked up. Ritvik is saying, yeah, glossopharyngeal nerve is affected. That is correct. Whereas in quinsy, it is the peritonsillar capsule area, and that's why it is usually unilateral, and it will not progress to a neck swelling. It will in fact push the uvula to the opposite side. Okay, so this is rhaphodotalgia is also there, like you're saying, because of the glossopharyngeal nerve that is coming over branches there. Right now, whereas when it is retropharyngeal abscess, you have to look at this widening of this prevertebral space. So in retropharyngeal abscess, there will be stridor. Okay, and Kavi, I just recently explained to you what kind of stridor will you see above the level of the glottis. You will see an inspiratory stridor at the level of the glottis. All right. right? So there will be a child with retropharyngeal abscess. The posterior pharyngeal wall will be, Ritvik is right, there will be inspiratory stridor, and you will see widening of this prevertebral space. Prevertebral space. You can see C2, C3. That is the area where they will be widening, and there will be inspiratory stridor. It is an emergency. What is the treatment for it is basically you have to first tracheostomize the child, secure the airway, shift the child into the operation theater, and then afterwards remove the abscess from the posterior pharyngeal, this retropharyngeal area. All right. Dot sign. Dot sign is seen in antroconal polyp. It is the space of air that is there laterally. What do you see in B over here? B is also an important image-based question. Yeah, Ritvik, intubation first. Yeah, so intubation, the risk is that you may rupture the abscess and cause aspiration. So generally, tracheostomy, if is given in the option, then choose tracheostomy first. See, when a child is having retropharyngeal abscess, they will also have torticollis, okay? Torticollis, because there is stiffening of the, the paravertebral muscle spasms. Very, very difficult to do any intubation in this case. Child is febrile, child is toxic. Better to do a tracheostomy, very easy to do in kids. It's superficial, not big, large thyroid coming in the way, and you can nicely, secure the airway first, save the life, and then you can drain it out. If intubation and tracheostomy both are given as options, I would go for tracheostomy. If there is tracheostomy is not the option and they just say secure airway or give intubation, then go for intubation. But practically, we have treated patients, children with retropharyngeal abscess, not easy to intubate because first of all, there is no space over there. The pharyngeal wall is pushed anteriorly. There is torticollis stiffness, child is toxic, and you may rupture. So that for those reasons, always prefer, a tracheostomy. What you see in B over here is this thumb sign. Thumb sign is seen in epiglottitis. Okay, and epiglottitis, of course, will also cause inspiratory stridor, and you have to treat with antibiotics. That is a very straightforward thing. These are the three views of the sinuses of the X-ray. Okay, so can you tell me what is A, B, and C? Very straightforward. We won't waste too much time over here. I'm sure you know this. Cadwell's view. Cadwell's view was asked in this last time's INI-CET. It is a frontal caudal view. You can see the frontal sinuses very nicely over here. B is Waters view, occipitomental view, and here you can see the maxillary sinuses. And the third one over here is you have to look at this intersphenoid septa, Pierre's view, or Pierre, French guy. All right, so this is same thing as Waters view, but with the mouth open. When you open the mouth, you are able to see the sphenoid sinus, same occipitomental view angle, but here you can see here you can't see the septa. Okay, there is no septa over here, but here you can see intersphenoid septa over there, and that will tell you whether it's Pierre's view or Waters view. Very, very straightforward, not wasting any time in this. Somebody was asking, I think Kavi was asking about this laryngotracheal bronchitis. Here you see very classical steeple sign. This image, exact image, has been asked at least 3 times in your PYQs. What is a steeple? Steeple is a church steeple. So when you see a church, see a steeple on top, and this kind of narrowing is seen in laryngotracheal bronchitis because it is growing edema. Okay, so there is all swelling and edema that is forming from the epiglottic area to the subglottic area because it is laryngeal infection going into the trachea and then going towards the bronchus. So it's laryngotracheal bronchitis, and that's why child first presents with barking, cough. It's also called croup. Okay, and here you will see if somebody is politically correct, clinically correct, they will say inspiratory stridor which progresses to biphasic. If the option is given between the two, you have to choose biphasic because eventually in laryngotracheal croup there will be biphasic stridor because it is involving both the supraglottic, glottic and subglottic region. All right, but in the initial stages when the infection starts, it is laryngotracheal bronchitis starts from the larynx, so that's why there will be inspiratory stridor. and afterwards it will go. This here you can see the normal CTPNS. Okay, there are three views of the CTPNS CT scan of the paranasal sinus. So CTPNS is nothing but paranasal sinuses. Okay, here you can see the maxillary sinus. You can see the inferior turbinate, the superior turbinate, middle turbinate, sorry, turbinate, middle turbinate. Because this is a bit posterior view, the middle turbinate has become thin. You can see the eyeballs, brain. All right. So this is called as a coronal section. This has been asked. What are the sections of CT scan to view the sinuses? So this straight, so the slices are taken with the face looking towards you. That is called as coronal section. If you are taking slices like this, okay, like you're cutting from the middle, from the neck, this is called as axial section. Okay, in the axial section, remember in CT scan, whatever is black is air, whatever is gray is tissue, and whatever is white is bone. Okay, so black is nothing but air or sinuses, and white bone, gray is tissue. Okay, so here you can see this view is better for the sphenoid sinuses, or you were seeing, and especially if there are adenoids and all of that, this is a good view to have. Okay, so please teach Haller cell many more. I am confused. Yes, Madhusudan, I have a very good image of Haller cell and Onodi cell, and trust me, of the way I'm going to tell you Haller cell, you will never forget it for the rest of your life. I think it is just in this only, one or two slides next. All right, this view is the sagittal view. Sagittal view is the side view. Okay, so coronal is front slices, axial is like this, and sagittal is the side view. Very good for sphenoid sinuses. Okay, this is the you can see over here, and also to look for adenoids and anything that is there in the air. Right, now I'm going to show you certain things. So I think like Madhusudan asked, can you tell me what is A and what is B? Okay, A and B. Let's to go. What is A and what is B? In the meantime, this is the maxillary sinus, this is the inferior turbinate, septum is straight, this is the middle turbinate, the orbit or the eye, this is the cribriform plate, where your CSF, rhinorias and all come. A is Haller, somebody said over delete kar diya. Okay, guys, now here is the imagination of the person who came up with this sign. I am not the one imagining like this and coming up with this sign, but you look at this over here, this shape like this and shape like this, and somebody has called it nipple sign, which is nothing but the anterior ethmoidal artery canal. Okay, so nipple sign is what is asked. You can see bilateral like this. Now B mein legendary Ritvik is saying agar nesai, Pratibha is saying Haller cell. Now let me tell you what this is. This cell, see, you have to see this bone. What is this bone? This bone is a very thin papery bone that is separating the basically the ethmoidal cells. You can see the ethmoidal cells over here. This is actually a pneumatized middle turbinate called concha bullosa. Okay, the concha bullosa, because in the middle turbinate you should not have air, but there is an air pocket over here. This is inferior turbinate, maxillary sinus. This bone is the lamina peperacea. Normally along the lamina peperacea you should not see any cell. Now this is a little bit of a local Indian or local Hindi slang, okay, ki L lag jate hain. So as an surgeon, if I am operating and I have gone into the ethmoidal cells, and I am now chewing the ethmoidal cells thinking that okay, this is, I am away from the lamina peperacea, but if I enter one of this abnormal cell over here, mere L lag jayenge, wo bhi double L, because one is to L lag ke lag gaye, and the second one is L for lamina peperacea, and the only word which has both these double L is the Haller cell. Haller cell में 2 L लगते हैं. Okay, and this Haller cell is the one that is there below the orbit. You have to remember the L of the Haller is for lamina peperacea, just as a way to remember. It was actually name of a guy called Haller जिसके बड़े L लगे थे जब whenever he must have caused some orbital injury, because we surgeons, if we don't know that this is there is an abnormal cell there, if we break into this cell, we may crack the lamina peperacea and we may cause, you know, injury to the orbital area or even blindness. The optic nerve is also very close there, or we may cause bleeding of one of the posterior ethmoidal arteries, and that blood may enter inside the orbit and cause a lot of compression injury or even proptosis. All of those problems, बहुत गंदा सीन है. L लगते हैं. Haller cell. Haller cell is a cell that you will see attached to the lamina peperacea at the level of the middle part of the maxillary sinus. You can see the maxillary sinus is almost becoming smaller, right? So it is almost at the posterior, it is the level of the middle turbinate, and this is where I think Madhusudan, you will not forget Haller cell, 2L, double L लगते हैं lamina peperacea and एक तुम्हारा L. Okay, now Onodi cell is on the other end seen in the sphenoid, and it's very easy to remember. You look at the word sphenoid and you look at Onodi. Half of the sphenoid word is already there rearranged, only that S and H are not there. Okay, the SPH. Otherwise, if you look at the sphenoid, yeah, sphenoid ka ENOID makes the ONOD. That's how I used to remember it. But ONOD will makes it sound like sphenoid. It is a cell within the sphenoid sinus. Okay, and this is also another problem, because if we enter this cell, we can injure all the lateral structures over here. There is the optic nerve, there is the cavernous sinus, and all of these things can cause a particular problem. That's why we have to do a CT scan before doing any surgery. So Onodi cells are in the sphenoid. Haller cell is attached to the lamina peperacea, so you should not get confused. And if they show any cell like this, okay, like see this over here is not lamina peperacea, this is not lamina peperacea, this is not Haller cell, these two are not Haller cell. Haller cell is one which will be connected to the lamina. That is the main thing you have to remember. L for Haller, L for lamina. All right, this is also commonly asked. All right, so this is a Horman-Miller sign in juvenile nasopharyngeal angiofibroma. The posterior wall of the maxillary sinus is arching forwards. Okay, right, so this is also very commonly asked. So this Horman-Miller sign, Onodi cell, Haller cell, and nipple sign have been asked multiple times, and concha bullosa has been asked, where you see the middle turbinate having air pocket. It is not ethmoidal bulla, it is concha bullosa. Bone having air is called concha bullosa, right? So there is another one over here. This has also been asked. You can see this big tissue inside the maxillary sinus, which is extending all the way up. It is also pushing the eyeball, so it's a very invasive disease. You may think it is some sort of cancer or tumor, but no. What you have to look over here is double intensities. You can see there is some white, you can see there is some gray. Okay, and this kind of dual contrast or double or what do we call it, heterogenic hue is seen in allergic fungal rhinosinusitis, AFRS. Okay, caused by aspergillus. Right, so this also has been asked in many ways. There are many major and minor criteria also for fungal, and one of them is fungal stain. Fungal biopsy is a minor criteria, fungal stain is a major criteria. So that question has been asked, but otherwise AFRS will have this double heterogeneity, mixed intensities that you can see. Right, now coming to vocal cords, guys, last part, very simple. This is a normal view of the vocal cord, so I can just tell you what are the normal structures that you can see. All right, this is epiglottis. Right, here is the vallicula, this is the median epiglottic fold, and this is lateral glossoepiglottic fold. Glossoepiglottic, this is the tongue, this is the epiglottic, so glossoepiglottic fold. And here is the two vocal cords. This area above is the false vocal cords. This is what is very hard for many students. and there is actually a gap between these two. True vocal cord and false vocal cord has a gap called as ventricle, and from there only the laryngocele comes, like Pratibha is saying. But this is not image of laryngocele. I will show you an image of laryngocele next slide. Okay, this you can see the tracheal rings. This is the posterior pharyngeal wall or the esophageal opening, and this is the pyriform. Pyriform means triangular. This is your food pouch, pyriform sinus. Okay, and this epiglottis to back called as the AE fold, aryepiglottic fold, from the arytenoid to the epiglottis. Okay, so this is very straightforward. What we are seeing over here, some of you are telling correctly, is this is the omega shaped epiglottis. Omega shaped epiglottis is seen in laryngomalacia. It's seen in children, all right. So B is laryngomalacia. It is a floppy, poorly developed epiglottis that closes, so it causes a lot of inspiratory stridor within the first 1 year. After the age of 1 year, it automatically calcifies and it is able to keep the airway open. But if you make the child lie down, the stridor worsens, so you have to keep the child in the prone position. So any postural change, they talk about less than 1 year baby with inspiratory stridor, self-limiting. After 1 year it will go away. All of this is laryngomalacia. This is the omega sign, okay? Omega epiglottis. Many times asked. Yeah, something 2 years. Yeah, different books, but generally I think what is believed evidence-based is 1 year. I doubt they will give you 1 year and 2 year as option. Whichever is closest, you can go for that. All right. Now, A, B, C. 3 clinical conditions of the vocal cords. Now you know what is where. A is asked quite a lot. Okay, here you can see that there are these nodules at the junction of anterior 1/3 and posterior 2/3. Junction is the part which has most amount of friction and fluttering. This is why this is called, this form vocal cord nodules. It's also called as singers nodules, also called as screamers nodules. Okay, because of a lot of vocal cord abuse. So here there will be history of some sort of profession, like a teacher, also called as teacher's nodule, singer, screamer. They will give you some hint and give you this image. In the second one, I think like legendary Ritik and Pratibha, you've all said this is a ring case edema. Okay, this is a ring case edema. There is some space within the vocal cord. Okay, that space gets inflamed, and vocal cords do not have lymphatic drainage. That's why vocal cord carcinomas do not drain into any lymph node. So this, all the toxins are not able to drain out, and here they will give you a history of smoking, very commonly seen in smokers because they're already pre-inflamed. Malwa block is like, अरे जनाब आप यहाँ पे हमारा जगह. Okay, so this is smoking, will be a history, ring case edema, and there will be a hoarse voice. Okay, a hot potato voice is in peritonsillitis, quinsy. Don't get confused. That is another clinical point that I want to mention there. Here in ring case edema, you will see a low pitched, gruffy voice, low pitched voice, because it cannot generate high tone. This, what you can see, can you see this little line in the vocal cord? This is called a sulcus vocalis, for which we basically injected with some fat or gel. This is new, when people have a lot of acid reflux and that acid reflux is causing vocal cord injury, then you develop this little sulcus. And because more and more cases of sulcus vocalis are coming, the examiners are beginning to ask and show, this change will be basically voice change, and sometimes using the false vocal cords. Okay, false vocal cord usage is called as pseudoplica ventricularis. Basically, the ventricle is the space between the false vocal cord and true vocal cord, and the patient is compensating and talking with their false vocal cord because the true cord having a damage or it is not vibrating properly because of this abnormal scarring called sulcus vocalis. Okay, now A and B are very importantly to ask. This you can see, it looks very scary, irregular, and it fixes the vocal cord. This is squamous cell carcinoma of the larynx. Okay, you have to know the TNM staging. The trick for TNM staging is whether the vocal cord is mobile or not. Okay, if the vocal cords are mobile, it is always less than T2. That is how you remember it. T3, T4 is when the vocal cords are fixed and there is either intralaryngeal or extralaryngeal extension. Okay, so that is the clue for it, and the treatment will be in this kind of case, of course, you will be radiation therapy and laryngectomy. But if it is just limited to the vocal cords, you can do a partial laryngectomy as well. Once it is stage 3, the vocal cords is fixed. Okay, so that is where the thing comes. Before that, T1 is single site, T2 is multiple sites, and then T3 is vocal cord fixed, T4 is extra laryngeal extension. So it's very, very logical. You don't have to get confused by trying to memorize it. This is what I was telling you about the mouse nibbled appearance. This is TB larynx. This is the only place where you will find a very, very painful speech, very, very painful vocal cords. Otherwise, all tubercular conditions are painless or very mild in their symptoms. But here you can see that the vocal cords have been like chewed up by the mouse nibbled appearance. Somebody in the past has. Okay. Now laryngocele, somebody was telling laryngocele. This is a laryngocele. You can clearly see that you cannot see the true vocal cords. Maybe if you focus over here, you can see the true vocal cords. They are hidden behind. Okay, you can see the true vocal cord is hidden behind. This is the false vocal cord, and in between there is a space from which this has come. This is a laryngocele. Classically, they will give you one word like either a trumpet blower or some sort of increase in pressure. Either professionally somebody is doing a lot of exhalation or blowing out air will be the history, and then it reduces. So this is a laryngocele. Coming out from the ventricle, the space between the true and false vocal cords. And if they give you this option of B, where it is a child with recurrent papillary, this is called recurrent respiratory papillomavirus. This is caused by human papillomavirus, I think 11 or 18. We can double check that, but you will see this recurrent papillary growths that are there, and this is called respiratory laser. Has a lot of role in surgery. How to differentiate between internal and external laryngocele? Internal laryngocele will not show outside. Okay, so this is an internal laryngocele. There will be main complaints of breathlessness, stridor whenever this pouch is out. But in external laryngocele, you will see that it has come out from through this space and it is shown visibly. And when the pressure goes down, it goes back. So that's how you'll come to know whether it is internal or external based on the outside and the inside visualization. Right now, here there is a lot of confusion. Both these are images from your PYQs. What is the difference between these two? I had taught this in one of the classes, and then there was confusion among students where they were saying that this is that. Okay, now I want to show you anatomically how to differentiate between the two. If you see any swelling, okay, any swelling that is anterior, okay, to the ear, if it is it's a swelling over here, this is a parotitis. This is a parotid swelling. Yeah, your phrase will be seen over here, but they will show some sort of sweating. There is no sweating seen over here. It is basically just a swelling that is anterior. So initially it will be less marked, and later on it becomes very demarcated circular swelling. Anterior is parotitis. But if it is more posterior and inferior, this is a Bezold's abscess. How to differentiate between anterior parotid abscess and a Bezold's abscess? A Bezold's abscess, many of you think it is in the neck, okay, but sometimes it is a child or it is a lot of neck space is there. Bezold's abscess is a complication of mastoiditis where the abscess forms along the sternocleidomastoid, which basically is coming from here only. All right. So this Bezold's abscess will be along the anterior border, and it will lift up the lower lobule of the pinna. And the presentation wise, it will be of course a hot tense abscess. Whereas in parotitis, initially most of the swelling will be anterior. Of course, in later stages, it will also lift up the pinna as it spreads, but it goes from anterior to posterior. Whereas this one is more posterior, it will never come anterior because anterior the parotid gland is there. So that's why you need to be able to differentiate between these two. The image is actually a question asked in your NEET PG with the answer being Bezold's abscess. All right. This is a very, very common question that is asked. Okay, this is your adenoid facies. Long face like the Tare Zameen Par Darshal Safari. The space between the nose and mouth is, there is a high arched palate. Crowding of teeth. Adenoid facies. Okay, these are the people who are most likely going to have some middle ear serous otitis media, require grommet insertion and adenoidectomy. This was asked just in the last FM also. This one over here is a mucocele. Okay, and there is something called as a plunging ranula. Plunging ranula is nothing but a large mucocele seen at the floor beneath the tongue. It's a location based thing. This, if it is on the lip, it is not, this is not a plunging ranula. Okay, this is a mucocele. All right, mucocele which is there, it can be a retention mucocele or a non-retention mucocele. Retention mucoceles are smaller. Non-retention mucoceles are the ones that will expand to the neighboring areas and will be larger. The non-retention mucocele in the floor of the mouth is a plunging ranula. Okay, so that is what I want. If somebody lifts up the tongue, you see a large swelling like this, that is a plunging ranula. So either that is asked, or a mucocele over a mucus retention cyst, or a mucus asked over. All right, this is oral candidiasis. There will be history of oral steroids or some immunocompromised state or some inhaler. Okay, because all of that is causing this whitish thing which easily peels out, unlike your hairy cell which does not peel out. All right, and now not get confused. D is what type, what are you seeing over here? You know what Haller's look like, you know what conca bullosa looks like, you know what Onodi looks like. This is a true test. What do you see over here, this arrow marked on the PNS? Okay, so you can see this is the middle turbinate, this is the, sorry, this is the inferior turbinate, this is the middle turbinate. So this over here is the superior turbinate. Okay, and it is called as a bullous superior turbinate because there is an air pocket inside. Okay, so like conca bullosa, this is a conca bullosa, is of the middle turbinate, and this is a aerated superior turbinate or a bullous superior turbinate. It is not a conca bullosa. Conca bullosa is the middle one. Okay, technically conca means bone. The word conca means bone, but a bullous conca is assumed to be middle turbinate. Superior turbinate, you call it aerated superior turbinate or a bullous superior turbinate. Okay, I think last two. Okay, so this will go quickly. What is this? This is a Bloom-Singer's voice prosthesis done after laryngectomy. This has been asked many times. Okay, so this laryngectomy stoma, but here you can see that there is a prosthesis. What is this prosthesis doing? It is a one-way valve. It is basically pushing the air. Whenever the patient's finger presses it, it will move the air from the trachea back into the mouth so that the person can speak. When he removes the finger from there, the air will come out for respiration. But when somebody wants to speak, they can just close the valve, the air will get pushed back into the mouth, and then someone can speak from moving and speech therapy. So this Blom-Singer's voice prosthesis allows people with total laryngectomy to speak. It is a silicone prosthesis. Okay, whereas this is a tracheostomy. because it's a common procedure. You are expected to know. A lot of questions come on tracheostomy. So initially when you do a tracheostomy, you will put something like this. This is the Portex tracheostomy tube, all right, with a cuff. And after 6 days, we'll change it into metallic Jackson's tracheostomy tube. And here you can see there are 3 parts. This third metallic, this one part is called as the obturator. This is basically assembled inside so that when we are passing it over here, it goes in smoothly. And then there is 2 cannulas. One is the outer cannula. This is the inner cannula. Okay, the purpose of the inner cannula is if any mucus gets stuck, you can take it out and put another inner cannula. You don't have to take out the outer cannula and jeopardize the patient's airway. Okay, and similarly you can do that with Portex. Portex also comes with the inner cannula. You can see there's one PVC cannula, and then there is a tube called 𝐒𝐿𝑖's. The 𝐒𝐿𝑖's is the same thing but silicone. It appears more white. You know, these 2 are asked, so that's why I am asking you. This is a self restraining mastoid retractor. Don't worry whether it is Jensen's or Mollison's or Ferguson. There is Agarwal's also available. People don't ask the name of it because it's very outdated. What you need to see over here is this part here. This thing is, what is this? Basically a self-retaining. So when we pose the mastoid and we put this retractor, nobody has to hold it. It will hold itself. That is why this is important. And this Kerrison's punch has been asked once in your NEET PG PYQ. It has been asked. This is the punch that you use to go into the agar nasi for endo-DCR, okay, for dacrocystorhinostomy surgery. All right, so as you know that now there is a software kind of a randomization of questions. So 1 or 2 questions when they have to pick from the nose, some dacrocystorhinostomy questions also get picked up, and that's why this has come. Now last part here, there is when there is CSF rhinorrhea, this is the target sign. And what you see over here is CT cysternography. What is happening over here? You can see it very clearly in the CT cysternography that there is contrast. You can see this whole white area on the top. Whole area is white. There is a dye. This dye which is filling up the blood vessels over here is coming and trickling. So that means there is a breach in the cribriform plate, and this CT cysternography, usually iohexol or some sort of a dye is used, and this CT cysternography is done. So this can be also asked for your CSF rhinorrhea. So guys, I think I would have covered at least a good 80%, 90% of potential image based questions. So I hope you get all of this in one place for your quick revision and look at all these images, because the questions are now becoming more clinical and more image based. So I hope this is helpful to you. If there are any other questions, put it in the comment section and I will respond to them. And if there are any images that I have missed, put that in the comment section as well, so that in future we can include it. But otherwise, more or less, this covers everything that has been asked in your PYQs and potential questions that can come. So all the best, guys. Take care. It's been a long time. You stuck along for more than 2 hours. Thank you. Signing out, Dr. Jagdish Chaturvedi.